why I said I'm going outside rather than putting the AC on. You can see what it's like. It's just lovely.
Dr. Ibrahim, just show us around
The wind is
quickly.
very nice.
Yeah,
It's just I said one of the places by the north coast that is lovely.
Dr. Ibrahim, just show us around.
Yeah, we'll stop our
It's
videos
one of
now.
the places by the north coast, next to my my sister-in-law's place.
Oh, great. We'll stop our videos and we'll
Okay.
keep mute ourselves. Only Dr. Ibrahim will keep his video and audio mic open. Okay.
Okay. When do you want to start?
Let's start, Doctor.
Okay. Good evening, everyone. It's my pleasure to be here with two good friends who are presenting and a great friend, Taufik, who is fantastic at organizing all these things. Today, we're going to be talking about treatment options for menopause. Now, as we all know, menopause is a natural biological process. It marks the end of a woman's reproductive years. It's officially diagnosed after 12 consecutive months without a period and typically occurs between 45 and 55. The transition is known as the perimenopause and can begin years earlier, as I'm sure all of you are aware. Now, the symptoms can include things like hot flushes, night sweats, mood swings, sleep disturbances, cognitive changes, the so-called brain fog, with an increased risk of osteoporosis and a cardiovascular disease later. Now, while the menopause is not an illness, symptoms associated with it can definitely impact a woman's life. So there are lots of treatment options available to manage these. Now, these can be broadly categorized into hormonal-based therapies and non-hormonal treatments. With hormonal-based therapy, obviously that's HRT. It's one of the most effective treatments for alleviating menopause symptoms, and especially hot flushes and vaginal dryness. It involves administration of estrogen alone or in combination of estrogen and progesterone, depending on whether the woman still has a uterus or not. Newer forms of HRT, such as bioidentical therapies, are popular among patients as they're the more natural options, but there is some debate about their safety and efficacy. For the non-hormonal options, women who choose not to take hormonal treatment or cannot for one or other reasons, several options are available, including the newer neurokinin 3 receptor antagonists, and Dr. Apana will be discussing these in greater detail, including the off-label use of SSRIs and SNRIs. Now, the plan today is for Dr. Marlene, who will be discussing hormonal treatments for the menopause. Will do her talk, and following that, Dr. Apana will give her presentation, and after that, we'll have a question and answer session. So, I think you've heard enough from me, and it is now my great pleasure to introduce a very good friend, Dr. Marlene, who will begin with her talk regarding the menopause. Dr. Marlene?
Thank you, Dr. Ibrahim, for the nice introduction to this session. And Taufik, thank you very much for organizing this. Why the menopause is important? We have to remember we are living for longer. 2 out of 3 women will reach their centenary. And 1 out of 3, sorry. 49% of the workforce is female. We are working for longer now, delaying the retirement because of the financial impact. Between the age of 45 and 53 are still part of the workforce. 63% of the women between 53 and 63 are still part of the workforce. The menopause is not just 12 months with no period. the menopause symptoms starts 2 to 10 years before the period stops. There is 42 different menopausal symptoms. And the first symptoms that start is the brain-related symptoms. The menopause is the disruption of neuroendocrine pathway. It's once our ovaries in the perimenopause, 2 to 10 years before the menopause, start fluctuating, start slowing down and eventually close the shop, which we call the menopause. There is significant disruption between the neuroendocrine. Estrogen is an important part of every cell in our body. Estrogen receptor is present in every cell in our body, whether it's our bone, joints, skin, eyes. In the brain, the estrogen is the wire that connects one nerve cell to the other. Estrogen plays an important role in allowing our neurons to utilize the glucose, and glucose is the most important energy source for our brain. So when the estrogen starts fluctuating, the first impact is on our brain. So the thermostat of our brain, the hypothalamus, stops working properly, hence the hot flushes, night sweat. The memory center is affected, so women start having a brain fog. In the middle of the sentence, they forget a word. They can see it, but it's not coming. It affects their memory. They go into a room, they can't remember why they went or where they left their keys. The processing slows down. It affects the emotional center, the irritability, they snap very quickly. The husband, I have women who their husband brought them to my clinic to be sorted out because they become really snappy and irritable, tearful, crying, unable to cope at work, get angry very quickly. The anxiety and depression is another element, and it creeps up slowly and women don't notice it. And they start feeling that they might be going through early dementia, which is not early dementia, it's just the drop of the estrogen. Hence, 10% of the 10% of the women in the perimenopause, menopause stop working. And, how significant is that? One piece of data is the data from the investment in Dubai showed that 32% of the property investment are by females. And usually what age the female is capable of, investing in properties in their mid-40s, late 50s. So these women, because they stop working, they reduce their working hour, they stop getting promotions. That's why it had a really significant impact on the whole society. Unfortunately, 25% of the 2.5% of the research is dedicated to women. So there is a huge delay in the research regarding women's health and especially menopause. It's really a topic that's completely ignored. In addition, later on, we end with the vaginal dryness, the painful sex, the decreased libido. They have the dry skin, dry eyes, itchy ears, feeling like crawly things on their skin, osteoporosis, the cardiovascular impact, and the diabetes. So these are really the important part that affects women's health. However, there is the most recent data is showing that one point is 70% of the people who have Alzheimer are women, not men. The drop of the estrogen affects the cognitive function. And as well, we start putting layers of amyloid in our brain, which is the one that predisposes, put us at risk of cognitive diseases such as dementia, Parkinsonism, and as well, it had been associated with schizophrenic disorders. So that's why, it's an important topic to manage properly. So we need to be aware there's 3 different types of estrogen, E1, E2, and E3. Estradiol E2 is the most potent, which mainly produces by the ovaries, and the E1, E3 are less potent, and they are metabolites of the estradiol, and estriol is the compound that is produced as a cream or a tablet that's used for vaginal dryness. However, estradiol valerate is what we use for, as part of the HRT. There is a lot of data showing about the vasomotor cognitive function impact. However, very interesting data, mainly it's a studies performed by Professor Lisa Mosconi, who is a neuroscientist in the USA, who was interested in Alzheimer because all the women in her family had Alzheimer, and she would try to find the predisposing factors. And what she found that in the perimenopause and menopause and postmenopause, there is significant decrease in the size of the gray matter of the brain, the size of the brain, and the weight of our brain. However, our body, our brain compensate and recovers after 2 years. It doesn't mean women are less, productive or functioning, or men better functioning than women. It just women compensate by working harder, by finding compensatory tricks to manage the physiological changes. We need also to include the increased incidence of premature menopause, the surgical menopause, and women who have menopause because of chemotherapy or radiotherapy for cancer treatment. So, what happens to our other parts of body in addition to the brain effect? 13% of the women have hip fracture in comparison to 3% of the men. The difference between woman physiology and man physiology, the man testosterone level drops very late in life in their 70s and 80s. However, in women, starts in the early 40s. And the first symptoms of menopause, which I forget of the perimenopause, which really we need to be aware of, is the irregular period coming every 2 weeks, the heavy period. When a woman presents with these symptoms, we need to ask them about other menopausal symptoms. So this is looking at the bone density scan. I'm sure you all well aware of the bone density scan. I'm going to show this graph. I'm going to increase the size of it. The graph shows the peak age of hip fracture in women is 63, in comparison in men, which is lower, but at the age of 83. And that's the huge difference between men and women. So, what's the benefit of estrogen? What's the benefit of HRT? This study showed a comparison between the background of a woman not having HRT and women having estradiol plus progesterone, 1 milligram and 2 milligram. What is interesting, at the 1 year, the 2 milligram have more beneficial impact on the spine bone density in comparison to the 1 milligram. However, after 1 year, there is no difference between the impact of on the spine density between the 1 and 2 milligrams. So both have similar beneficial effects. So, you know, as Dr. Ibrahim said, women are coming to us. They want bioidentical HRT, which is the topical HRT. So, is there any difference between the topical or oral estrogen on the bone density? There is no significant difference between them. Both are equally beneficial, and both are licensed as prophylaxis and as well as treatment of osteoporosis with less risk than the other raloxifens that we use for osteoporosis for the right woman. And that's a very similar study. So all the guidelines, including there is a new NICE guideline published this year on HRT, had showed that HRT is beneficial for vasomotor, for bone density, and genitourinary benefits. The guidelines differ. The British is mainly focusing on starting with the lowest dose. However, they all agree we need to individualize our approach to our of HRT to different women. So risk of HRT, I mean, the downside of the downhill use of HRT started with the WHI study, the American study, which was published in 2002, 2003. Unfortunately, the problem with the WHI study is they used one conjugated estrogen, which have higher risks. Two, they used medroxyprogesterone, which is now we know is associated with the highest incidence of breast cancer. However, they started HRT in women in their 60s and 70s, and all the guidelines agree less than 10 years of menopause and advise not to use it above the age of, not to start it above the age of 60. So, the British Million Women study that came after that showed an increased risk of breast cancer. At the 5 years, there was extra 4 women. At the 10 years, extra 10 women in 1,000 developing breast cancer. And the problem with that study, one, they recruited patients from the breast clinic, women who go to the breast clinic because of increased personal risk of or family risk of breast cancer. And they, in the UK, they do the breast screening every 5 years. So women were not screened. In the data analysis, they included women who had been diagnosed with breast cancer in the first 18 months of starting HRT, and we know it takes longer time to develop of the breast cancer. And these are the disadvantage of this study. So the current data all in agreement that 23 out of 1,000 women develop breast cancer. If these 1,000 women are obese, double the risk, goes up to 46 women. If these women are smokers or they drink 2 units of alcohol per day, add extra 8 women. If they use HRT, after 5 years, just increase 4 women. So we really need to explain to our patients these data. So, I mean, this all studies are showing the same thing. So who are at increased risk of breast cancer and who should not have HRT? Personal history of hormone-sensitive breast cancer. If it's non-hormone sensitive, we need to liaise with their breast cancer specialist. BRCA1, BRCA2. Women who have a first-degree family history of breast cancer under the age of 40. And one male member in the family, no matter what age, with breast cancer, that usually indicates genetic risk. So, so this is the BRCA. the risk of breast cancer in the BRCA1 group after the age of 70 goes up to 70%, and the ovarian cancer in the BRCA2 after the age of 70 goes to 27%. Hence, a lot of women go through prophylactic oophorectomy and mastectomy, including Angelina Jolie, which everybody knows about it. The problem with this group of women, they immediately hit the menopause, which is horrible. So the PROSE study, which is a British study, looked into the impact of using HRT in women who have prophylactic oophorectomy and mastectomy who have BRCA1 and BRCA2. And the data reported after 3.5 years, they reported, they put it as there was no decrease of benefit of the prophylactic mastectomy and oophorectomy with using HRT after 3.5 years, which is really very interesting data. This graph basically, it summarizes what I was talking about of the WHI study, and you can see the highest percentage of HRT in the UK. 70% of the women was using HRT in the perimenopause, menopause, and that suddenly dropped significantly. Worldwide, 32% drop. However, in the UK, the GPs all stopped it, and just in some hospital we were using it. And I remember I was doing a menopause clinic with Margaret Rees, the expert of menopause at that time in Oxford in 2004. And she was dishing it like smartest. And I looked at her and why. And she would always say to me, you can never put a price to well-being. Now I understand, working with HRT, how much positive impact it have on women. So the next few slides, basically, it's all coming about the guidelines published in 2023 in the UK for the GPs about prescribing HRT safely. So who are eligible for HRT? As we said, hormone-sensitive breast cancer, women who have BRCA1, BRCA2, endometrial cancer, endometrioid ovarian cancer, personal history of DVT and thromboembolism or thrombophilia. If there is a strong family history of thrombophilia, it's worth sending these women to the hematologist for screening, and BMI above 40. And as well, we need to remember, we need to start it under the age of, if women have menopause within the 10 years. However, we can use vaginal estrogen for a total of 6 weeks, every 6 months, without progesterone. And the Royal College guidelines is vaginal on a daily basis for vaginal atrophy for 2 weeks, after 2 weeks, twice weekly for a total of 6 years. There is no increased cervical cancer. So what is the check? The guidelines says you need to take a full history, including family, personal history, surgical history. Definitely, we need to make sure they are up to date with their breast screening. Mammogram guidelines, the British, the American, and the WHO, 40 to 50 yearly mammogram, 50 onward every 2 years. Need to make sure they smear. However, we have to remember the main prescribers of HRT in Europe are the family doctors and the GPs. They have no access to ultrasound. We are gynecologists. We are sitting in a clinic. The ultrasound is just beside us. Transvaginal ultrasound will show us if there is any adenomyosis, if there is any endometrial pathology, or ovarian cyst and ovarian pathology. The size of the uterus and the presence of adenomyosis will allow me to decide what dose of progesterone and what regime I should use. So the primary care guidelines for HRT use divided it into 4 regimes. Regime number 1 is for women who don't have a uterus and no cervix, because if they still have a cervix, we need to use progesterone because there might be some endometrial cells inside the cervix. So for women who have no uterus and no cervix and and didn't have the hysterectomy because of severe endometriosis, you can use for them estrogen-only HRT, whether it's topical, gel, or the patches, or vaginal estrogen, you can use it on its own. The regime 2 is for women who still had a period within the last 12 months. It's sequential HRT, as the first half of the packet have estrogen only, and the second half of the packet have estrogen and progesterone. However, be wary with women with endometriosis, adenomyosis. Using sequential HRT for them will make their endometriosis flare up, and they can develop chocolate cysts, and they will come back to you and say, I'm in pain, I don't want the HRT, it's of no use to me. So these group of women, we need to use for them the continuous HRT. And regime 3 is for women who had been menopausal for no period for at least 12 months. We can use the continuous HRT. So so what is available in Dubai is a limited option, and for patients' sake and easy understanding, I call it, breast-friendly HRT or non-breast-friendly HRT. The breast-friendly HRT, we are talking about the bioidentical HRT. The estrogen is not bioidentical. The estrogen is body identical. The estradiol valerate is identical to our own estrogen. It's manufactured in a lab. The progesterone is the bioidentical that comes, it's a micronized progesterone that comes from yam, that comes under the name of Utrogestan in the UK or in Dubai, or the dydrogesterone, which is a progesterone that is the molecule is very similar to our natural molecule, except on the C carbon molecule is different from our identical progesterone. Testosterone. Estrogen and testosterone plays a role in reducing the insulin resistance. Hence, the insulin resistance goes up in the perimenopause and postmenopause. Testosterone plays a role in the muscle mass, our energy, metabolism, sex drive. So a lot of women need testosterone. We normally start with estrogen and progesterone. If they still have low sex drive and low energy, then you can add testosterone. Unfortunately, the testosterone available is a man dose. The man dose is 50 and the women dose is only 5. So what is available here and in the UK is the Testogel that is at the dose of 50. So we normally advise the women to use a tiny weeny bit of it on a daily basis and finish the sachet over 7 to 10 days. Then she will be taking her proper dose of estrogen. So how do you start using estrogen? So if we are using it for women who have premature menopause, they need a higher dose of estrogen. So the 1 milligram of estradiol valerate in the tablet form is equal to the 50 in the gel or the patch. So in women who are menopausal, we start with the lowest dose, the 110. However, women with premature menopause, we start with the highest dose of the 2 milligram. After 6 weeks or so on the 1 milligram of estradiol, If they are still having symptoms, then we can increase the dose to 2 milligram and continue the same. In women who are menopausal, the 1 milligram is more than enough for them. But we have to remember we need to individualize. So I said what we use in the WHI study is the conjugated estrogen, which come from the horse mare. And personally, for me, this is non-ethical. They keep the horse pregnant all the time to get the estrogen. And whether we use the estradiol dydrogesterone, which is now available in the Dubai markets, as being important. The other HRTs, we are actually individual hospital importing them themselves from Europe. So all of them have beneficial effect, on all the menopausal and perimenopausal symptoms. However, the advantage of the estradiol and dydrogesterone over the conjugated estrogen and medroxyprogesterone, the better lipid profile. The dydrogesterone estradiol lowers the low density lipoprotein and increases the good cholesterol, the HDL. So that's the difference between them. I said insulin plays a role in estradiol plays a role in insulin resistance, and whatever dose you use, it lowers the fasting insulin and as well it lowers the glucose. So safety, this is the WHI study, the long-term study reported at the 20 years. It compared the conjugated estrogen on its own on the incidence of breast cancer and the mortality. The blue lines at the bottom is just conjugated estrogen on its own, and the top line is the estrogen and progesterone. And you can see on the long term, the estrogen, whatever type, it is associated with lower incidence of breast cancer. HRT is associated with increased incidence of endometrial cancer. Continuous HRT have a lower incidence. Micronized progesterone as well is associated with increased incidence of endometrial cancer. However, we always need to balance the dose of the estrogen with the dose of the progesterone. If we have to increase the dose of the estrogen because the woman is still having hot flushes, still having symptoms, one, we need first to check her estradiol level to see if the absorption is good, or we need to change to a different type of estrogen as we switch from topical to oral, or we increase the dose, but we need to balance it with the right progesterone. As a gynecologist, I do recommend to do an endometrial assessment every 3 to 6 months, because if you see an endometrial thickness, this is the time to do a hysteroscopy, take endometrial biopsy to minimize the risk of endometrial hyperplasia and endometrial cancer. So on the breast cancer risk, I'm going to jump. As I said, progesterone type is really important. This slide is very interesting. The pink is women, the risk of breast cancer in women who are not using an HRT. The second graph is with dydrogesterone. There's no significant increased risk of HRT, which showed with a lot of the studies. However, the one after is the medroxyprogesterone, and then the highest incidence of breast cancer is with norepinephrine. This is where the type of progesterone plays a role. This is as well the Lancet study, and in summary, it's exactly the same. It's the type of progesterone have a significant risk, depends on what type. Thromboembolism, Micronized progesterone is not associated with increased risk of thromboembolic event. Estrogen in its own topical is not associated with increased risk of thromboembolism. However, I would still not prescribe it for a woman with a personal history of DVT or pulmonary embolus, because any further event is a life-changing. It's not like they will drop that. It's a life-changing, and that's how I counsel my women. So with dydrogesterone, there is no significant increased risk. That's how the data, how the research had shown. However, with micronized, there is no increased risk. And this is very interesting slide. It's basically both conjugated estrogen. The purple one is the conjugated estrogen with progesterone, and you can see there is increased risk of breast cancer, stroke, heart attacks. There is prophylactic benefits to the osteoporosis, the vaginal dryness, genital urinary. However, with estrogen, with conjugated estrogen on its own, there is no significant increased risk of strokes and thromboembolism. So, so in summary, different parts of the world, women have different age of menopause. The lower socioeconomic have the earliest menopause. In India is 46, in the USA is 49, and in Europe is 52, the average age of menopause. There is strong socioeconomic. In summary, HRT is beneficial. It reduces the incidence of Alzheimer. The bioidentical HRT reduces the incidence of Alzheimer by 70% as degenerative brain diseases, and the oral reduces the incidence of degenerative brain disease by 45%. However, lifestyle is essential. Changes, healthy diet, avoiding processed food, and exercising. And we need to assess individual women and prescribe individually. Thank you very much.
Thank you very much, Dr. Marlene. It's a really lovely talk, very informative. It's a pleasure to hear it. Now I'll call on my colleague, Dr. Aparna Guma, now a good friend who's going to talk to us about the non-hormonal treatments for menopause. Dr. Aparna, please go ahead.
Thank you, Dr. Ibrahim. It gives me great pleasure. It gives me great pleasure to be on this platform, like with my eminent colleagues, and thank you, Tawfiq Ali, for organizing this excellent webinar comparing both aspects of the menopause management, because HRT is one big aspect of it, and a lot of people has fear about HRT. So I'm going to talk about non-hormonal management and then look into treating a patient as a holistic approach. And of course, like patients should have a choice about whether they wanted to go into HRT, but it could be a combination. It is not exclusive, like, independent of each other. So we can give a combination of the treatments. So menopause, Dr. Marlene has beautifully touched upon a lot of aspects of the menopause and made my job easy. So I'm just quickly going to go to menopause. And I think one of the questions I get asked is, why is it called menopause when it's to deal with the females, right? So mens means monthly and pauses means cessation and stopping. And it comes from a Greek word, which is very natural and inevitable phase of the life. And happens like, Dr. Marlene has touched on the last slide. Depends on where you are with the socioeconomic and geographical location. The age at menopause can vary with regional and ethnic variations. And of course, if the menopause happens early, before the age of 40 is considered as premature ovarian failure or premature menopause. This slide can, summarize how many symptoms the woman will suffer as a result of the menopausal changes. It looks busy. That's because...
Dr. Aparna?
Yeah.
Doctor, I'm sorry to interrupt. Could you maybe share your screen?
Oh, okay. Is it not coming? Okay, let me just see. Can you see now?
Yes, perfect. Thank you.
Okay. Okay, can you see now?
Yeah, maybe you just, that's it. Yeah, perfect.
Yeah. So this slide shows all the symptoms that happens around the menopause. Like, it looks busy. That's because women suffer through so many symptoms of the menopause. And you can see the range of symptoms. And one slide, it will show like from head to toe, the woman can suffer through all the symptoms of the menopause. So this is looking in a funnier aspect, but it's by no means funny to go through the menopause. The woman on the left side is showing menopause has its advantages, but too bad she doesn't remember what they are. And another woman says like, I'm going through the menopause, so please call me back in about 5 years. And then one of the doctor wants to give a chocolate, so to help the woman to cope with the menopause. Okay. So what can we look through when we look through the menopause? Like what are the most common symptoms? Around 85% of the women suffer with hot flushes and night sweats. That's the most common symptoms. And the evidence shows that they can last for several years and with an average duration between 5 to 7 years as a suffering. So non-estrogen treatments for hot flushes are effective in some people. None of them work as well as the estrogen, but they are like better than no treatment and do give relief, especially if the woman doesn't want to go through HRT. So let's look at the complementary and alternative medicines and non-hormonal treatment options. So in about 2002, in the early 2000s, only less than 50% of the women were interested in looking at this. This is a women's health study across the nation, but like look at 2080, it's 80% and more women are getting awareness about menopausal symptoms and want to know their options about both HRT and non-hormonal treatments as well. So currently the percentage is going up to 90%. Like as I said in the before, we can look at the woman to treat as a holistically and combination of the treatments that can help them. And they prefer conventional therapies to alternative therapies because they consider the complementary and alternative medicine to be more natural, more safe, and having positive effect on maintaining good general health. And they presume that it will have like no or mild side effects, which is not always true, but I will go through that in the next slides. So let's look at the lifestyle changes. My colleague has touched upon already like few of the lifestyle changes. So these are very easy to adapt. And then all the women, like no matter whether they are going on HRT or not going on HRT, they will benefit from these lifestyle changes. So for example, stopping smoking is very important and having a healthy diet, not to have the processed diet, and having a balanced diet can help not to put on weight, because one of the things in menopause and perimenopause, significant complaint about weight gain, especially in the midriff section. And they say we are eating the same thing, we are doing more exercise, but why are we putting on weight? So this is one aspect of it to look into, like healthy diet along with exercise. And what to do, like, simple treatment options, like simple advice, like, suffering with hot flushes, we can ask them to layer down and layer up depending upon like whether they're feeling hot flushes or night sweats, and sleeping in a cool ventilated room. If they are getting hot flushes, that can help them to stay cool as well. Regular exercise is important. I'll have a next slide to show what kind of exercise we should be recommending to the woman. And these do not reduce the symptoms. To some extent, they will reduce it, but most importantly, the woman will start to feel well so that, they find it easier to tolerate the symptoms as well. And avoiding spicy food and avoiding excess alcohol and caffeine is also helpful to cope up with the symptoms. So the healthy diet should have like several servings of the vegetables per day, along with some fruits, and whole grains are very important. And eating oily fish at least twice weekly, and that will increase the omega-rich foods as well, important. Reducing the total fat content within the diet, as well as salt and alcohol along with caffeine consumption should be limited. These are coming from the International Menopause Society recommendations. So let's look at this slide. This will summarize what the woman should be looking at, all the different aspects of it. So coming to the exercise, we should be advising the woman to have a regular exercise to reduce cardiovascular as well as total mortality in this group of women. Optimum exercise is at least 150 minutes of moderately intensity of work. The intensity of aerobic activity should be taken into account depending on how they feel and what's their exercise tolerance previously. So we don't want to somebody like, start having fractures or having any injuries, sports related, if suddenly started taking up the sports. And also if the BMI is high, they should be guided to lose weight in a healthy way slowly over the time, at least 5 to 10% to improve many abnormalities associated with insulin resistance syndrome and to reduce the risk of pre-diabetes, which could be associated in this age group. Again, this comes from IMS recommendations. So what about breast cancer patients? Dr. Marlene has touched quite a bit about the breast cancer patients. So what about these young patients who are already diagnosed with breast cancer and who experience premature ovarian failure due to the cancer treatments? And severe hot flushes can have a major impact on the quality of life in this group of women. And especially for patients with hormone-dependent tumors in high-risk patients, they always worry about recurrence of the breast cancer. So they chose not to go on the HRT, but they could be looking at other options to help them cope with the symptoms. And some of these groups of patients are recommended to have extended treatment up to 10 years. And that means the negative influence on the climactic symptoms and the menopausal symptoms and suffering could be prolonged in this group of women. So let's look at other aspects of the exercise. And is aerobic exercise, strength training exercises are the only recommendations? No, they could do yoga as well at the same time. There was a systematic review and meta-analysis was done specifically looking into yoga for menopausal symptoms, which has given a lot of benefits. It will improve the psychological aspect, somatic aspects, and beneficial to the vasomotor as well as the urogenital menopausal symptoms. So it's associated with general health benefits. So we should be recommending the women to take up yoga regularly. And this is published in 2018. There was a systematic review and meta-analysis details looking into the yoga. What about psychological therapies, psychosomatic aspects of it? CBT has been recommended. Cognitive behavioral therapy has been demonstrated to improve and reduce the vasomotor symptoms and to significant effect. And there also was studies done about hypnosis has been shown to reduce the vasomotor symptoms. And also patients do complain of having anxiety and palpitations, which are associated with perimenopause and menopause. So this has shown to, have a significant improvement by doing hypnosis therapies. And also patients should be looking into mindfulness and breathing exercises and relaxation therapies at the same time. So there could be a whole lot of combination of the things, like simple way of doing these things to help them cope up with the symptoms. So what about the herbal and plant supplements? People tell us they're using black cohosh and they're using red clover. They're using quite significant treatments which may or may not have been proven. So, and what about the soya? Soya has been shown in the past, people used to drink a lot of soya milk, eat a lot of tofu, but no amount of eating large amount of tofu will give you the estrogen which is needed. So they can reduce the vasomotor symptoms to a little extent, but the evidence is inconsistent. And black cohosh has been tried by many women. A meta-analysis has showed that it's a comparable benefit to very low dose hormonal treatment and has a good safety profile. So as I said, people start using evening primrose oil, which can help with the mood swings associated with perimenopause and menopause. And people use various different products with black cohosh or ginseng or St. John's wort used to be very popular many, many years ago, but it has shown significant side effects. Therefore, it's not recommended to use it anymore. There is another compound called purified pollen extract, which is a supplement sourced from pure pollen extract, and which is not available in all the places, but it has a beneficial action of selective serotonin reuptake inhibitors. There is no contraindications to use even if patients had a pollen allergy. And it has, again, beneficial to reduce the hot flushes, and up to 65% reduction was observed with using the purified pollen extract when it's available. And acupuncture has shown a lot of women do go and try acupuncture and they feel that, there is no harm in trying anything that could help and, beneficial and the complementary therapies. And acupuncture, again, a meta-analysis has been done along with the systematic reviews and RCTs to compare it. And there is an improvement in also health-related quality of the life. And there are no particular side effects other than, of course, the pain with the needles at the time. So this guideline is taken from British Menopause Society recommendations. I used to practice in UK and run my private menopause clinic for several years before moving to Dubai. So again, let's look at these alternatives to HRT, which comes from BMS recommendations. There are several medications which were looked at, such as gabapentin. I will go into different slides in a little bit more details. Pregabalin has been compared as well to improve the quality of the life. And these are all controlled drugs. So in Dubai, again, like, the controlled drugs are very, has to be not given by the gynecologist, and, it's not like easily as well. And clonidine used to be many, many years ago. Clonidine was very preferred treatment before availability of the HRT, and the safety of HRT has been proven. And we do not use clonidine anymore, but like it used to be popular with patients with hypertension and going through the menopause. And let's look at selective serotonin reuptake inhibitors, which classify into the group of antidepressants. And I will go into different ones that can help through the hot flushes and several menopausal symptoms. So these are all the group of drugs, like going into the SSRIs and SNRIs. SSRIs such as paroxetine, fluoxetine, citalopram, and sertraline has been shown to help with hot flushes mainly. And SNRIs such as venlafaxine has been used in UK. We used to use quite regularly in patients who had contraindications for HRT or who is very scared and afraid to go on HRT. We used to prescribe venlafaxine. Again, it has shown that there are some side effects, of course. It can decrease the libido and then, decrease the sexual dysfunction, but it can improve the hot flushes to a significant effect. So let's look a little bit more detail into this group of medicines with SSRIs and SNRIs. So they are very effective alternatives and reduce the intensity anywhere between 20 to 65%. So how do they work? The mechanism of action is they regulate the changes in the thermoregulatory center in the hypothalamus. When women go through the menopause and perimenopause due to estrogen deprivation, the hypothalamus thermoregulator is set to a different temperature. So therefore, the hot flushes happens, the vasomotor symptoms becomes very frequent, whereas SSRIs and SNRIs, by decreasing the serotonin level, they re-regulate the thermoregulatory center in the hypothalamus. So therefore, the women do receive the benefit from these symptoms. So they act very rapidly, and it could be as early as in a couple of weeks, women notice a significant difference. And SSRIs, which are commonly used, are fluoxetine, paroxetine, citalopram, and sertraline. And SNRIs, mainly venlafaxine group of medicines, are prescribed. Which has, and then again, because of the side effect profile with nausea, dizziness, or headaches, and depression, they need to be looked into to see which group of medicines has the best safety profiles. And out of these, paroxetine, citalopram, and escitalopram carry the better profiles. And also we need to be giving advice to the women. SNRIs can increase the blood pressure. So if the patient is already hypertensive, they need to be closely monitored with the blood pressures. Because of the side effect, quite significant dropout at the end of the 3 months, like patients may want to stop the medications or come off it. So what is the regular dose that can be given for these medications? Venlafaxine can be started at very low dose at 37.5, but needs to be increased to 150 milligrams to show the benefit. Paroxetine and citalopram are given usually at 10 milligrams per daily, and paroxetine has a better evidence compared to other medicines with a side effect profile. And fluoxetine has evidence of efficacy, better efficacy, and lower incidence of side effect profile as well. So let's look at the gabapentin. Gabapentin is mainly anticonvulsant, which is an analog of gamma-aminobutyric acid. And a systematic review has confirmed that it does improve the hot flushes significantly, but it has to be used at 300 milligrams 3 times a day. So that means 900 milligrams per day of the dose. And RCT has looked at 12 weeks user profile, increasing gabapentin to 2,400 milligrams and compare with estrogen, mainly Premarin at 0.625 milligrams daily. And gabapentin seems to be equally effective at this dose with estrogen. But we do not give at this dose. This was just a study which was done, but usually preferred dose is 900 milligrams per day. And they do see benefit within few days itself. And they do have increased sleepiness which can be acting as a drowsiness for these patients. So that needs to be monitored as well. And if we needed to stop it, that needs to be tapered down slowly. Otherwise, they'll have a withdrawal symptoms. So maybe people has heard about this wonderful medication, which was thought to be like quite significant replacement to HRT. This is called fezolinetant, which is a neurokinin 3 receptor antagonist. And all over the world, like there was a lot of excitement. This was approved in Australia initially, then in UK as well. This is not available in Dubai. And how does this work? The mechanism is it targets the neural pathways with K and DY neurons involved in hypothalamic regulatory center. And it reduces the frequency and severity of moderate to severe vasomotor symptoms and reduces sleep disturbances. The women report that the sleep quality and quality of life in general are significantly improved. And they start with a dose of 30 milligrams to up to maximum 45 milligrams per tablet. And initially it was very much hyped and, this was seen as a replacement to HRT. But recently there were concerns about the liver function, so then patients needs to be monitored for liver function at the beginning as well as within 3 months of the treatment. And if the woman chose to continue on this, then periodically has to be reviewed because there could be significant alteration in the liver function with this medication. So recently, again, this taken like hot off the press in July 2025, MHRA, which is from Medicines and Healthcare Products Regulatory Agency, has become the first regulator in the world to approve another component, which is elinzanetant, for the treatment of moderate to severe vasomotor symptoms. So this was come through the NICE regulated and is supposed to be a private prescription, which should be easily available. So let's wait and see, next few months, what will be the feedback about this medicine. So what about the breast cancer patients who do not want to be on HRT or who are contraindicated to HRT? Can they try the SSRIs or SNRIs if they do not want HRT or worried about the recurrence? Yes, they can, but what is the side effect? Patients who've been on tamoxifen and has been reported with alteration with SSRIs and SNRIs, they will inhibit the CYP2D6 enzyme. So therefore, there is a decreased absorption of the active metabolite of tamoxifen. So patients can be still on tamoxifen, but it may not be as effective if they chose to be on SSRIs or SNRIs. Again, so that needs to be kept in mind and to be discussed with the oncologist as an MDT meeting to see what is suitable for this group of patients. Again, for this group of patients, venlafaxine and desvenlafaxine are the better compared to citalopram and escitalopram group of drugs. What about oxybutynin? This has been reviewed again to see whether it be useful to treat moderate to severe vasomotor symptoms in a different group of studies. This, you may all be aware that this is used for urinary urge incontinence and OAB, overactive bladder, which is anticholinergic and antimuscarinic medications. And the doses could be very slow to start with very low dose with 2.5 to 5 milligrams, and then start with once a daily and increase twice a daily up to maximum 15. But as you know that if you use it for urge incontinence or overactive bladder, they will have a side effects of dry mouth, confusion, and constipation as well. So there needs to be careful in elderly patients if there is a cognitive decline as well. So clonidine, I do not want to discuss too much about it as we do not use it, and I hope that is not being used in the rest of the parts of the world as well. It used to be a licensed indication in UK for the management of hot flushes, especially preferred in patients with hot flushes, but we do not use it anymore because we have very much better alternatives to use. Again, there was a lot of research done into stellate ganglion block as well, injection of anesthetic agent to block the sympathetic nerve chain. And I'm not sure anywhere in the world, this is under research purposes only. It's not being used outside of the research profile. So what about the vaginal atrophy? So we talked about a lot of, alternatives, treatments to hot flushes and night sweats. What about vaginal dryness and vaginal atrophy? What can be used? So again, there could be a lot of estrogen preparations are available as hormonal preparations and DHEA and then testosterone preparations to help with the libido and side of things. What about non-hormonal medications? There is a lot of choice over the counter as well available with moisturizers and lubricants, but hyaluronic acid has been looked into. Quite a few preparations are available to help moisturize the vagina, reduce the dryness, and phytoestrogens has been looked into. And vaginal vitamin E, vitamin D creams as well. Again, this has not become popular. And oral and vaginal probiotics treatments and moisturizing agents with hyaluronic acid has been tried. And there was an evidence-based treatment in the North American Menopause Society has recommended hyaluronic acid to be prescribed regularly just to improve the moisturization and lubrication. There were 2 systematic reviews done as well. It has shown to improve the vulvovaginal symptoms, especially if the woman feel discomfort or itching or dryness, as comparable as that of the estrogen in local preparations. So what about other treatments, the neo treatments, the laser treatments? So the laser treatments has shown to be has a high satisfaction rate in patients as well as healthcare providers as well in improving the lubrication and reducing the vaginal atrophy. And patients do have significant symptoms of recurrent UTI. And when you do the urine culture, there would not be any infection. So this is mainly because of the lack of estrogen and vulvovaginal atrophies. So how does the laser work? It improves the vascularization, neovascularization of the vaginal mucosa and stimulates the synthesis of the new collagen in the connective tissue. And also it makes the vaginal epithelium thick, so therefore less prone to infections, like women come back with recurrent candidiasis and bacterial infections in this age group along with vaginal dryness. So the laser has shown to be improving all of these symptoms. And also because of this improvement, it has shown the life and sexual activity and sexual satisfaction in this group of women. I think this slide will be really useful to note down to see what are all the options like, pharmacological, non-pharmacological, how do we manage the vaginal atrophy and dryness treatments. So on the left side with the non-pharmacological, to summarize, you can see the CBT, hypnosis, acupuncture, and they can try along with the lifestyle modifications and diet, of course, in a combination, exercise and yoga. If none of these treatments are available, like, not working to the satisfaction, then they can go into the combination, both pharmacological and non-pharmacological combination of the things. Again, as I said in the previous slides, looking into SSRIs and SNRIs, again, you can see how this is tapered doses to be used and how patients should be evaluated and specialist referral if the symptoms are still persistent. The woman on the left side, like, vulvovaginal atrophy, are specifically having vaginal dryness symptoms, but not significant vasomotor symptoms. They could try the local preparations to help along with the laser if needed. So let's look very quickly into osteoporosis. Again, osteoporosis, there are many treatment options available. HRT is like very good treatment because estrogen will reduce risk of osteoporosis, especially the women who are prone to develop it. But let's look at prevention of osteoporosis and advising the woman to do stop smoking and then strength training, resistance training exercises, along with lifestyle modifications, dietary changes, and vitamin D, calcium intake as well. So this guidelines again comes from BMS. Like, if you're interested, you can go on to the British Menopause Society to look into non-hormonal based treatments where they evaluate different treatment options. So you could use this for the reference as well. So this is very good. You could see like how they compared like, benefits of each different treatment modalities in the non-pharmacological options. So Vitamyotics, like Tawfiq Ali, who has sponsored this, like, we have a very good, wonderful product with Menopause Original as well as Menopause Plus, which gives like, a lot of multiple supplements that will help reduce the symptoms. And women, when they come with history of fatigue and tiredness, and I will always prescribe them and recommend this to them so that their energy levels will be improved. So these are the references if you wanted to further look into with the BMS consensus statement or non-hormonal treatments published in the BMJ, and IMS Society, International Menopause Society, has quite valuable information for professionals as well as patients to look into. So thank you. This will be my last slide. And I just like to look at this middle slide, comparing the teenager, and there is a new word called queenager. Okay, both are looking hot. teenager because of the dressing and because of the age, and the queenager because of the menopausal symptoms. So thank you very much for listening to me. I hope you have gained some valuable information to listening to me and my colleague, Dr. Marlene. Thank you.
Thank you very much, Dr. Aparna, and thank you, Dr. Marlene. I hope everybody here is aware how lucky we are to have two experts in the field giving these presentations for us. Got a couple of questions. First one is, I think probably directed to Dr. Marlene, but obviously I value Dr. Aparna's input. How do you counsel a patient on HRT that she will stop it at some time later in her life? This is from Dr. Razan. Good evening, Dr. Razan.
Good question, Dr. Razan. After taking a full history, I will, and the patient have no risks, and I've done all the checkups. I don't start HRT unless I have an up-to-date mammogram, just to make sure I'm not starting on somebody with have breast cancer. And I will discuss with her the benefits, the risks, and decide accordingly up to her wishes. And definitely I document that in the notes. I have a leaflet that I put everything in writing, and I give it to the patients. The leaflet, I got it from the NHS website, and we are finalizing putting it in a nice form in King's Hospital to give it to all our King's patients. It's really as simple as that. Risk of thromboembolism, breast cancer, endometrial cancer, importance of having the screening and the follow-up.
Sorry. Thank you, Dr. Marlene. Dr. Aparna, would you like to add anything?
Yeah, thank you. I think previously we used to say, like, you should be on HRT for 5 years only, and then you must come off it. And, this is all based on the old information of the HRT and misconceptions that came off the WHO studies. So now there is no limit to stopping HRT. Like, the woman can carry on as long as they wish to carry on, as long as they do the annual follow-ups and checkups. And if she does choose to stop it sometime later in the life, and one of the things they will come back and say, doctor, what will happen if I stop it? Like, will I get my symptoms again? Again, there is no definite answer to this. And each person, like, has an individual, like, how the body is going to react to see. Sometimes they may come back with symptoms, and sometimes, like, the symptoms can intensify if they stop it. But on the other hand, there is a percentage of the women who will cope brilliantly and may not, suffer again. Like, so it all depends on the individual patients, what they choose to do and how they're going to cope. And if they do start having symptoms again, they can always go back onto HRT, because IMS and BMS recommendations currently are, there is no need to advise a patient to stop HRT, because, the previous risk which were validated by the WHO studies are like misconceptions. So the risks all changed now, and the new phase of thing is they could carry on as long as they wish to.
Okay, thank you very much. Another question from Dr. Muhammad is, what does a patient do if a topical estrogen is not available on the market and she suffers from vaginal dryness? Maybe we'll start with Dr. Aparna in this case.
Yeah, so as I said in there, Dr. Muhammad, thank you for an excellent question. Again, like, there are local different preparations, like it could be simple hyaluronic acid creams, vaginal moisturizers, and also laser treatment, as I have elaborated in my slide, that could improve a significant vulvovaginal atrophies. Being in Dubai, you will see PRP treatments as well, like women, like, going through different options of the treatment available. But moisturization and then vaginal lubrications can also help with the hyaluronic acid preparations along with laser treatments.
Thank you. Dr. Marlene, anything to add?
I think the only thing to add is in Dubai, aesthetic gynecology is really popular. Many gynecologists are providing this service. And in addition to the laser, especially if there is vaginal weakness, they do for the vaginal dryness. And all these things do really work. But hyaluronic acid is fantastic.
Okay, thank you very much. Our next question is from Madam Newesu. I hope I pronounced this right. I apologize if I didn't. Says, hello team, thank you for the presentation. I started my menopause at the age of 38. Any reasons to worry? Because this seems premature menopause, and what is your advice to me? Another concern is that I always hear that someone's menopausal age depends on when their mother had her menopause. I asked my mum and she said it occurred at 48 years, while mine was at 38 years. Could there be a problem? We'll start with Dr. Marlene, please.
So really, that is a fantastic question. The age of menopause, we are seeing more and more premature menopause. The things that affects our ovarian reserve is endometriosis, surgery on the ovaries, adenomyosis because it's an inflammatory disease and it destroys our follicles, and there is increased incidence of drop of the ovarian reserve in women with endometriosis, adenomyosis. The other thing that is associated with the drop of the AMH and early menopause is actually immunological disorders such as Hashimoto, Sjogren's syndrome, and other autoimmune disorders. So all my patients with premature menopause, I send them to the rheumatologist to assess. One point, HRT is essential in premature menopause. And the risk of using HRT for women who have early menopause is non-existent because we are replacing what the ovaries would have been producing at that point of time. And so it is essential to have HRT to minimize the cardiovascular and the cognitive risks, as well as the bone and the vaginal dryness and the eye dryness. So, in women who have very early premature menopause at the age of 28, 30, 32, some of them would get pregnant spontaneously. And in these cases, the type of HRT we use is progluton, which comes from Bayer, and Femiston, which comes from Abbott, because the type of estrogen and progesterone in it does not suppress ovulation. And I've written a case report where a woman got pregnant on 3 occasions on progluton with premature menopause. Yeah, so that's my answer.
Thank you. Dr. Aparna?
Yeah, sorry to hear that, you're going through premature menopause. And again, there could be several reasons, as my colleague said, to see. Sometimes it could be genetic, but not always. There could be several other causes that could cause premature menopause. And most important thing is to go on to HRT so that we reduce the risk of osteoporosis and improve the cardiovascular life quality as well. Like for the long term, it would be beneficial to be on HRT. Also looking at as I said in the previous answer, there is no need to stop HRT. Like usually we used to say at least minimum is till you achieve the natural age of menopause, which is again around 50, 51, you must continue and recommended to continue on the HRT. And the benefit could continue afterwards. Like there could be assessment, and also DEXA scans is very important to regularly have the DEXA scans and lipid profile to be checked so that could help with the cardiovascular health aspect as well.
Thank you. There's another question from Dr. Muniz Gajda. In a postmenopausal woman with thin endometrium, 3.4 millimeters, I started on Femiston 1.5 after baseline breast and pelvic ultrasound. After 2 months, she presented with heavy bleeding. A repeat ultrasound showed an endometrial thickness of 5.4 millimeters with some fluid collection. An endometrial biopsy has been taken. How commonly do we see such bleeding on low-dose continuous combined HRT within such a short duration? And should we be concerned about endometrial hyperplasia even if her initial endometrial thickness was normal? Dr. Aparna?
Yeah, hi. Thank you for the question. Again, like, the cutoff is 4 millimeters of endometrium if the patient is on HRT. Again, so initially, the first 6 months of starting HRT, irregular bleeding is to be expected. So the evaluation is to do baseline test at the beginning before we start the HRT to see the initial pelvic assessment and endometrial thickness and evaluation and assessment so that we can reassure the patient as well as reassuring ourselves. So in the up to 6 months, this is very common to have the irregular spotting. That means the patient is responding, or we may need to adjust the doses of the medications. Once the cutoff has gone up and you will need to do endometrial biopsy just to check and see if there is any endometrial hyperplasia, anything is going on. So we need to alter the dosages to see if it continues, biopsy results comes back as normal and we are reassured ourselves and the patients, then they should be advised to continue on the HRT. But that means we need to look at the doses of the estrogen and progesterone. Maybe we need to do a hormone analysis at that point to see whether we need to increase the estrogen doses or whether we need to increase the progesterone combinations to see what works for the patient. So there is no need once the biopsy is done and we are reassured.
Thank you, Dr. Aparna. Dr. Ma? Sorry.
So postmenopausal bleeding is a very common problem. And the Royal College guidelines in women who have postmenopausal bleeding, if they have if they are not on HRT, endometrial thickness up to 4 millimeter, you don't need to do anything. Endometrial thickness above 4, you need to take an endometrial biopsy. In women who are on HRT, the cut point actually depends on what you look at, which study goes up to 7 to 8 millimeter. So 5.5 millimeter is not thickened endometrium for women who are on HRT. In this scenario, I would just maybe add an extra 10 milligram of dufastone to do a little bit of more balance and then repeat the ultrasound after a couple of months. If you are really worried, take a Pipel endometrial biopsy. However, the cut point is 6 to 7 millimeter for taking an endometrial biopsy.
Thank you. Now, the next question links into something that crossed my mind as well. How do you reduce lower abdominal fat, which started during the menopause, change lifestyle, doing exercise, healthy diet, but lower abdominal fat is not moving? I wanted to ask you if there's any evidence of research regarding Mounjaro or Ozempic with regard to menopausal symptoms and menopausal fat. So I'll let Dr. Marlene take this one first.
Yeah, so the abdominal fat is so related to the insulin resistant, and it's the one that is associated with the highest risk of cardiovascular problems, and it reflects the visceral fat. And very interesting, the recent data, and there is a lot of data showing that vegan diet or vegetarian diet significantly lowers the percentage of the abdominal and the visceral fat in comparison to even healthy normal diet. So no processed food, exercising, combining cardiovascular and weightlifting. Plus, it's a hard job. Mounjaro plays a big role, and it significantly reduces the abdominal fat because it reduces the insulin resistant. And there is a lot of evidence, and I can't remember the figures of the benefit of Mounjaro on the lipid profile as well as the fat percentage in the body. But it's part of the aging process, and that's what I explain to my women, is in our 20s and 30s, our body needs
Thank
the
you.
basic
Dr. Aparna?
metabolism is higher.
Yes, again, that's a very good question, Dr. Ibrahim, to ask. So along with insulin resistance, and then, there is a lot of disturbances that will happen with
Thank you,
the
Dr. Marlene.
steroid pathways and, sleep disturbances. and anxiety and stress levels and steroid pathways being disturbed with the hormonal imbalance at this time. So that will all contribute to increasing abdominal girth and visceral fat and negative cardiovascular effects. So, I mean, our population, like our laziness could be anywhere in the world. So I don't know what is availability of Mounjaro compared to Dubai, where it seems to be very, very popular and, to help reduce the insulin resistance and reduce the adiposity. And Mounjaro is having significant benefits. And I'm seeing a quite large number of patients asking me this question to say, they've done the strength training, they went into the diets and, they're not either eating less and less and healthy, clean eating, clean living, strength training, but they're still struggling to reduce menopausal belly. This is called menopausal belly. So they're struggling with it. So they're all asking, doctor, what is your recommendation? Can we go on Mounjaro? So sometimes I don't know what is the right answer, because Mounjaro does seem to, help a lot of significant groups of women. Then I say, as long as, is prescribed through the endocrinologist to help control the insulin resistance is also a problem. Then in little doses, low doses, it may be beneficial to help if they've done everything else. And also one other thing I wanted to add on what Dr. Marlin said about the vegetarian diet, cutting down the sugar, especially sugar seems to be a problem. So if they control down the levels of sugar they take as well, it seems to help reduce the weight, especially the menopausal belly.
Thank you. An interesting question from Dr. Tahira. Patient has estrogen and progesterone and negative breast cancer being treated completely, has severe vasomotor symptoms. What is your take here on giving HRT? We'll start with Dr. Aparna. Dr. Aparna, did you
hear me? Yeah. So this was a question about breast cancer, estrogen and progesterone receptor negative.
Hello? Anybody?
Yeah, it's just
Sorry,
your line is not very good.
Again.
Dr. Ibrahim, you're breaking
That's
up.
right, being treated completely and has severe vasomotor symptoms. What's your opinion on giving HRT? I'll try and find a better link, but let's try with this one.
Okay. Dr. Marlin, do you want to go first or do you want me to answer?
No, go first because I couldn't hear the question properly.
Yeah, so the breast cancer, which has been estrogen and progesterone receptor negative, treated completely, patient is suffering with severe vasomotor symptoms. Again, see, there are two aspects of management of these patients. So patient needs to be thoroughly counseled, and then they could be offered a hormone replacement treatment as long as there is a regular surveillance is going on. We are discussing with the oncology team in a multidisciplinary meeting, and patient being monitored regularly, then HRT can be given in low dose in a topical preparations. That's one aspect of the treatment. And the second aspect is if the patient is worried about the recurrence of the cancer, breast cancer, and wanted to try complementary and alternative treatments. As I have mentioned, there are several treatment options with SNRIs is available. Venlafaxine group of patients can treat these patients if it is just suffering with severe vasomotor symptoms. That will seem to have a significant beneficial effect, and they could try all the alternative treatments as well.
Yeah, I think I completely agree with Dr. Aparna. If they're really suffering badly, can use a topical HRT, but working closely with the breast cancer team, with the oncologist and the breast surgeon, and monitor them really, really closely and giving them the lowest dose possible. Plus, definitely things like menopause, omega-3, selenium, CQ10, the antioxidants are beneficial as a part of holistic approach to improve their energy level and their well-being, and maybe valeriana to help with their sleep, which is a herb. all these improves their general well-being and their hot flushes incidence. But yeah, have to work closely with the breast team.
Thank you, thank you. Another interesting question. This is an anonymous attendee. Any role for melatonin low dose use in menopausal symptoms? We'll start with Dr. Marlene.
Melatonin had been shown to be beneficial in sleeping. And yeah, it's a lot of menopausal women use it to help them to sleep, but it's of no help in other menopausal symptoms. Other things to help with the sleep is valeriana, and definitely utrogestan, the micronized progesterone, is fantastic as a sleeping pill. The only side effects of it is a woman fall asleep very quickly. But melatonin, yes, helps for sleeping only.
Sorry, thank you. Dr. Aparna?
Yeah, as Dr. Marlene said, it's just for sleeping purposes, no other benefits for, menopausal symptoms. And it acts similar to, people who are jet setting, traveling will use melatonin and it will be the same purpose. But other thing they could try as well is the magnesium supplements. And
Oh, yeah.
patients are getting very good benefits like, magnesium glycinate, especially the preparation of the magnesium glycinate helps with the sleep disturbances and also reduce the anxiety by neuroregulation. So women come back and say they're sleeping like a baby once they started on magnesium.
Thank you. I mean, I have to thank our listeners. There are some very, very interesting questions here. There's one from Dr. Anita. What's your opinion on ovarian tissue transplant to tackle early menopause?
Mhm.
Okay, so I do know that I've been talking to a medical director in Abu Dhabi and Elaine. And Abu Dhabi, they're through the Department of Health, like Ministry of Health, they started doing research trials, injecting stem cells into ovaries. And in the being Dubai, and as we talked about aesthetic gynecology, PRP treatment is being used as well. Again, these are all research trials. Like it has to be a lot of larger group studies to see. Trials needs to be done to see maybe stem cells would have a role and benefit in future, but we are not there yet, and it's just being done as a research purpose in Abu Dhabi. So watch the space for future.
Okay, Dr. Aparna, anything to add?
So it's stem cells injection into the ovaries is used, and there is small data showing that there is 10% incidence of 10% pregnancy rate after stem cells and PRP in the ovaries. However, it's not FDA approved, and we are still not aware of the risk of cancer with using stem cells. They're also in the IVF unit, they are using a growth hormone to help. And I guess women who are really desperate to have a baby, who have premature menopause, are willing to try everything to help them. But we have to watch the space and the data. It's not yet FDA approved.
Thank you. Thank you. A question from Dr. Sayeda. 32-year-old patient with staging laparotomy, TH and BSO due to borderline ovarian tumor. I'm not sure what the findings on the laparotomy were. Is tibolone safe to use as an HRT? We'll start with Dr. Malay.
So, tibolone. Traditionally, we are taught tibolone is safe for breast cancer. It's safe. It's breast cancer friendly. However, tibolone is not breast cancer friendly. Tibolone is associated with increased incidence of breast cancer. HRT, all the HRT is not contraindicated on ovarian cancer, whether it's malignant or borderline. It's only contraindicated in women with endometrioid ovarian cancer, but borderline tumor, it's not contraindicated for them using HRT.
Thank you, Dr. Malay. Dr. Parna?
Agree completely with Dr. Marley. Like, there are many alternatives and better treatment options. We have moved on from Tibolon long time ago. So there are other safer alternatives to look into.
Thank you. So another question from Dr. Ravindra. I'm sorry, I've just lost that. How do you manage hypothyroidism-induced menopause? Dr. Aparna.
So again, like as Dr. Marlin said previously, like autoimmune, diseases, and presumably they're asking about autoimmune thyroiditis. Sometimes they do have like pernicious anemia, diabetes, and other conditions. And autoimmune thyroiditis shouldn't necessarily cause premature menopause or anything. But sometimes you do see association in this group of patients. Again, counseling of this group of, especially if they have failure or premature menopause, to be treated along with the endocrinologist to manage the thyroid conditions, and counseling about HRT in this group of women to be done.
Thank you. Dr. Marlene?
I completely agree with Dr. Aparna. These women, you manage them jointly with the endocrinologist who manages their hypothyroid, and you manage the early menopause, and you layers together. Plus, you need to make sure that you assess their lipid profile and do a general health, the bone density, and all these things. For these women, even if they are under the age of 40, I would start for them the breast screening in the form of breast ultrasound on a yearly basis. And there is no guidelines to say doing that, but I would prefer to do that for these women who are on HRT very early on.
Okay, thank you. Now, I have an interesting question from Dr. Muniz. Is there any real clinical value in getting a Dutch test done before initiating HRT in postmenopausal women? Follow-up prompts: do estrogen metabolite patterns on Dutch test actually guide the choice of HRT or its route? And can Dutch test testing before HRT predict risk of adverse outcomes with breast tenderness? We'll start with Dr. Marley.
I'll tell you, the new NICE guideline that is out of the press commented on it. It's of no value whatsoever. It's a new fad. There is no evidence of its benefit. I wouldn't do it.
Okay, Dr. Aparna?
Agree, completely agree. If you have too much money to waste it on other things. The Dutch, people come with like 20 pages printed. What is the cortisol levels, estrogen levels, circadian rhythms is of no use in managing.
Okay. One that I think will be difficult for you ladies to answer, but we'll ask you, because I don't think there's any evidence for any treatment for this. What is your advice regarding delaying or preventing menopause?
Well, there
Dr.
is a lot of advice, like healthy living, clean eating, strength training, and looking after yourself, doing the best you can to have you can do yoga. Yoga has shown to delay, reduce the symptoms, also delay the onset as well. So I think these are all the things, not having any diseases, of course, like if you can help it, but it's not possible. But I think lifestyle advices, as I put in my several slides, to follow through, and stopping smoking, reducing caffeine, alcohol. So these are all things will be beneficial to delay as long as possible. And nobody can escape the genes, but at least we can do our best and to try and postpone or reduce, if it comes, at least reduce the severity of the symptoms.
Thank you.
So,
Dr.
Ibrahim, I'm sorry to disappoint you. There is evidence. The
please go ahead.
latest research from Dr. Lisa Mosconi showed that a healthy diet, we are talking Mediterranean diet, no processed food whatsoever, mainly fish, and the amount of the food, and exercising can delay the menopause up to 3 years. This is really interesting data. However, the data on Mediterranean diet and exercising, these two interventions on their own reduce the risk of Alzheimer by 45%. And data published last year on Alzheimer patient, 5 lifestyle changes, vegan healthy diet, walking every day, yoga, meditation because it reduces the stress level, and team meeting on a weekly basis because elderly people become isolated. It improved the cognitive function significantly after 6 months of these intervention. At the 5 years, these are people diagnosed with Alzheimer. At the 5 years, the people who had continued with these intervention were still living at home, being independent, walking on their own. So lifestyle changes is better than any medication under the sun.
Perfect. Okay, we have a question now that's right up your alley, Dr. Marlene. In a postmenopausal woman with a known history of endometriosis, HRT was initiated for severe vasomotor symptoms, but she presented with reactivation of endometriotic pain. What precautions should we take in such cases?
So it's the dose of the progesterone which is really essential. If the woman is perimenopausal, the type of HRT I would use for this woman, which is available here and in Europe, is the combination of 2 milligram estradiol and Dynagest 2 milligram. It's continuous, 2 milligram estradiol and Dynagest in Dubai under the name of Velbian. It's fantastic for women with endometriosis who having bleeding problem and pain problem. It controls their vasomotor and their pain. However, I used topical estrogen for women who have endometriosis and severe endometriosis. But even with the low dose of estradiol of 50, I would use a high dose of the micronized progesterone of 200, not 100. And if they have symptoms, then I will switch. The data on the Dynagest, it doesn't affect the clotting. It doesn't affect the lipid profile, neither the sugar profile nor the liver function. So very interesting. So that's my approach.
Thank you, Dr. Aparna.
Again, same like using a topical preparation of estrogen will not increase the recurrence risk of endometriosis with the topical preparations and the right combination of the progesterone doses so that, the endometriosis doesn't recur and then cause pain. So that's what most of the patients worry about. Sometimes they wanted to put up with the severe menopausal symptoms, especially if they underwent, hysterectomy with the removal of the ovaries or ovary removal on itself. They worry about recurrence of the endometriosis. So they should be reassured with the right dose of progesterone and topical preparations. They shouldn't be worrying about these things.
Fantastic, thank you. There's an interesting question here from Dr. Srikant Tiwari. What is the best time to take the Menopause tablet?
There is no best time. Anytime in the perimenopause, menopause, I have fantastic benefits from it.
I think they mean time of day.
Oh, it doesn't matter. In the morning after breakfast.
Dr. Aparna?
Agree, same.
Okay. And another question from Dr. Anita. Fertility treatments have a great impact on ovarian function. How does that impact the depletion of ovarian reserve leading to premature ovarian failure? In other words, can we say too much of ART leads to early ovarian failure and need for HRT? Dr. Marlene.
No evidence whatsoever that ART causes any depletion of the ovarian reserve. We have millions of follicles. We have to look into what was the cause of the infertility. And 40% of the infertility is related to endometriosis, and that's usual, and adenomyosis, and that's usually the cause of depletion of our ovarian reserve rather than the ART itself.
Okay, and we have a question from Dr. Jaya Lakshmi for Dr. Aparna. Thank you both for an excellent presentation and valuable insights into HRT. What percentage of women in the UAE are receiving HRT? She indicates that many Asian women have declined HRT. I'd like to get both your views on this. So Maybe we can start with Dr. Aparna.
Yeah, so very good question, Dr. Jayalakshmi. Thanks for asking. And coming from UK 2.5 years ago, where I used to run the menopause clinic, and HRT is like well known to the patients all over in UK and general practitioners and everyone. Coming to Dubai, it was a cultural shift. So there wasn't much awareness. Like the doctors are also prescribing, like, not in the same way we were doing in UK, because there wasn't much awareness. Therefore, we can see the webinar, what we are doing passionately, Dr. Marlene and myself, is trying to educate as well. So now I have seen 2.5 years down the lane, I see there is a cultural shift, and Dubai is international population. So a lot of expats from UK, USA, and other countries, European countries we see, who are very much forward, and then who are very keen and ask, and they do research, they talk to their within WhatsApp groups and Facebook groups, and very much aware of it. The Asian population and the local Emirati population, sadly, not that much are aware of need for HRT. So they're still worried, and they still read all this old information about the WHO studies, and they still have the misconceptions to understand the HRT. But I do see it slowly. There is a cultural shift, and women are asking and coming forward about this.
Okay, thank you. Dr. Marlene?
So HRT is becoming more and more popular in all communities, whether it's Asian, African. I have women coming from Africa specifically for HRT. I think the shift in the world and the media and even Obama's wife is talking about HRT. Oprah Winfrey is talking about HRT. So you see more demand for it still, and it's women talking to each other. And I see a lot of Arabic women who basically, it's a group of friends, one telling the other, and they are coming for HRT. However, still in the Emirati group of women, there is, in the old generation, I had a lady last week. I was heartbroken. She came to the clinic with her husband. I can see she dragged him to the clinic. She's desperate for HRT. She is suffering, depressed, can't leave the bed, hot flushes, she can't sleep. And for 45 minutes, he argued against HRT. So me and Dr. Aparna are doing a lot of work with a group of doctors who are passionate about it in Dubai to increase the awareness and involve the DHA as well with this important topic to increase the awareness of it. And then it's woman's choice to decide whether she wants to go on it or not.
Thank you. Thank you. I have another question here from Dr. Lucia. Thank you for the webinar. One of the side effects, the patient is 54 years old, taking menopause hormonal therapy, 210 in the last 2 months. She has had no pathology, abdominal scan has shown a thin endometrium, but now she has bleeding. Should we change her to the 110?
No, don't change anything. You can't judge the HRT in the first 3 months. You can have bleeding in the first 3 months. And if you started the HRT within the last 12 months, as she's not been through menopausal in the perimenopause, you are more likely to have this pattern of bleeding. It eventually settles down. If she continues bleeding after 3 months, consider switching her to the continuous HRT rather than the sequential HRT. If the 1.5 is not enough for her, as she's still having hot flushes, actually I'm doubling the dose. I'm giving her 2 tablets. So technically I'm giving her 2 milligrams of estradiol and 10 milligrams of dydrogesterone. But it's not available except if I give her a 2-tablet form. But give her time.
Thank you, Dr. Aparna.
Yeah, it has to agree. As we said, in initial 6 months of starting HRT, this is a very common symptom, especially if you done the scan and the endometrium is thin, and there could be continuous combined preparation to continue. So that will sort itself out in a few months' time.
Thank you. I'm sorry, I lost my track here. I was looking at the questions and the question list keeps changing. From Dr. Razia, is it necessary to take supplements like vitamin D, calcium, etc., even if there are no menopausal symptoms and a patient is of menopausal age, especially if they're obese, when the symptoms can be hidden? Dr. Aparna?
Yeah, I would recommend taking supplements like, but we do need to be careful about where you are living. Like, in Dubai, vitamin D levels are very low. So we do recommend patients to take vitamin D. Depends upon where you are living, whether your diet is good. But if a patient has, obesity, high BMI, they will have higher risk of bone pains and joint pains as well. So depending on the analysis and the health checkup, they could be recommended to take vitamin D and calcium supplements. There is no hard and fast rule about it. So it depends on the individual patients and where you are living geographically.
Thank you, Dr.
It is the two vitamins which are important for our energy, function, hair, bones, is the vitamin D and B complex. However, these two vitamins, we should never overdose on them. So I assess my patients, I do vitamin D and B12, and accordingly, I prescribe vitamin D or B12 if it is required. Recent data had shown that women who are on estrogen plus vitamin D and calcium, their bone density is significantly better than women who are on vitamin D only or women who are on estrogen only. So we need to check the vitamin D and make sure they have supplements of it. Vitamin D and B12 level, the normal range is in the middle of the range. Like vitamin D is between 30 to 110. We should aim to keep women at 50 or 60 level. So if it is above 30, I would use 10. However, I would monitor their vitamin D level every 6 months just to make sure I'm not overdosing.
Thank you. Another question from an anonymous attendee. Is there any correlation of skin condition with the menopause? For instance, persistent itching and nodule formation or any other autoimmune diseases? We'll start with Dr. Marlene.
So the two well-known symptoms of perimenopause and menopause is itchy skin, dry skin, and feeling like crawly things on the skin. Once you improve the estradiol level in the blood, as with giving HRT, these symptoms significantly improve. But you need to exclude, a skin disorder. So if you are worried, send them to the dermatologist.
Thank you. Dr. Aparna?
Yeah, again, estrogen deficiency has been well known because it changes the collagen with estrogen deficiency, and the matrix of the collagen and glycoproteins changes the skin, leading to itchy, scaly skin and the changes. And, the women don't feel young after going through the menopause because they can see all the skin changes due to the collagen changes in the body. Again, it shouldn't be nodules or anything, but persistent dry skin and, need to be advised to have moisturization along with estrogen supplementation. Autoimmune conditions has shown to be slightly increased incidence as well in postmenopause patients. Again, needs to be worked together with the dermatologist and rheumatologist depending on the significance of the symptoms they're presenting.
Thank you. Thank you. I have a question from Dr. Tipti, which I think is probably straightforward for both of you to answer. Do treatments like chemotherapy and radiotherapy trigger menopause at an early age? We'll start with Dr. Aparna.
Of course, depending upon, whichever chemotherapy and radiotherapy treatment options, they always have a significant side effects, unfortunately, and one of them is premature ovarian failure and premature menopause, so that could affect the fertility depending on the age group of the patients. So sometimes it's recommended that the patient do egg freezing before they're going for chemo and radiotherapy treatments if fertility is going to be an issue and family is not complete. And women do suffer, depending on the type of cancers and severity of the chemo radiotherapies, they do go into premature ovarian failure and premature menopause. So HRT is an ideal option of treatment for this group of patients, again, with a careful counseling.
Thank you very much. Dr. Malin?
I completely agree with Dr. Apana, and the only thing I would say, with my background of oncology is we used to suspend the ovaries before giving radiotherapy for cervical cancer to prevent premature menopause. However, even chemotherapy for leukemias can cause premature menopause. So we always try to do egg freezing for these women before they start their chemo or radiotherapy.
Thank you. There's another question. There we go. This is an interesting one. We'll start with Dr. Marlene. What is the role of HRT for those who want to still look young, meaning want to maintain skin elasticity with minimal or no menopausal symptoms, but just a high FSH?
NICE Guidelines 2025 said, don't use HRT just as anti-aging. Don't recommend HRT as an anti-aging. However, HRT, if you started early, research had shown the earlier you start HRT, the better positive impact on our cognitive function. That for me is more important than how I look. Is my brain still functioning? It improves the skin elasticity, reduces the risk of osteoporosis and fracture, keeps the vagina healthy, stop it from shrinking and becoming dry, but it's not an anti-aging stuff. It reduces the cardiovascular risk, but it's a general health issue rather than a facelift.
Okay, thank you. Dr. Aparna.
Yeah, of course, there are numerous benefits to HRT, and one of them is looking young and feeling young and, having a great quality of the life. And I remember an incident when I was in UK, one of the patient came with like 20 pages of paper cuttings to say her GP asked her to stop HRT after 5 years. This was, I was talking about 8-9 years ago, and she insisted, she was like 63 already. She insisted she wanted to continue on HRT because she doesn't want to look wrinkly and she wants to feel young and beautiful as she is now till she is like 80. She said, Doc, I wanted to, till the day I die, I wanted to look young and feel young, and, I take the other risks of HRT. At that time, there are still all these, presumed risks were there, like with the breast cancer, increased risk and everything. So we said, as long as you are aware of it and we explain the risks to you, you come for your annual screening and you do your breast screening and mammogram, you can continue. And now the IMS Society, International Menopause Society, and BMS come up with recommendations to say we shouldn't ask the patient to stop HRT as long as they're aware of it, and whatever benefit they're looking for, with all the other major benefits of bone protection, cardiovascular protection, and reducing the risk of Alzheimer's and dementia, so be it. If they want to look young and feel young, let them continue.
Thank you. So I have a question here from Dr. Moniz, which is an interesting question because it comes down to protocols, really. After initiating HRT in a postmenopausal woman, how closely should we monitor endometrial thickness in an asymptomatic patient? What is the threshold of endometrial thickness on ultrasound that would prompt further evaluation? And last bit is, what is the actual risk of endometrial hyperplasia or cancer in a woman on continuous combined HRT? We'll start with Dr. Marlene.
So I've forgotten the first part of the question. I think I need HRT.
How closely should you monitor the endometrial thickness in an asymptomatic patient on HRT?
As I said in my presentation, there is no guidelines because the doctors who prescribe HRT in Europe, there is a limited resources in the NHS and the National Health Services all around Europe. They have no access to ultrasound. So the guidelines and the new NICE guideline, there is nothing called ultrasound as part of the assessment. However, us gynecologists prescribing HRT, I would do personally the ultrasound. Depends on the patient. If she have any postmenopausal bleeding, she needs ultrasound, even though she is on HRT, to assess the endometrial thickness. However, I will definitely do it every 3 to 6 months. Depends on each patient. The cut point of the endometrial thickness for women on HRT with postmenopausal bleeding is 7 actually millimeter. That's the UK guidelines. I was head of oncology in the UK in my previous life. And that's the cut point. And there's no actual guidelines whatsoever. And I don't think we'll have any guidelines. Professor of, she's the head of the International Menopause Society, an Italian professor. She came to us in King's and I asked her to give us a lecture. And she clearly said, unfortunately, in Italy, we have no doctors available to do ultrasound. We have no gynecologists enough available to see the patients. And the recommendation is to review every year. But there's no chance I would be reviewing my patient every year. There is a lot of tweaking you do along the line. You add magnesium, you add other vitamins, you change the dose of the estrogen, the progesterone. There is a lot of tweaking until the patient feel really well.
Okay, Dr. Pardon.
Again, as my colleague said, Dr. Marlene said, it depends on where you are geographically and what are the resources and facilities available in which part of the world where you're practicing. Being in UK, because of the resources and where we work in NHS, the setups are different and patients come for 6 monthly or 1 yearly follow-up and long waiting times. But being in Dubai in private practice, I always do a baseline assessment before I start the patient on HRT to satisfy myself and the patient to make sure that we are not missing any endometrial thickness or polyps or anything else and having a regular pap smear, all the checkup. And in Dubai, the insurance-based practice, the patient needs to come every 3 months for the follow-up for the refill prescription. So, and then I will always ask the patient to say, let me know if there is any spotting or irregular bleeding or any unusual symptoms you're noticing. So there is no specific guidelines. Again, North American Society recommends something else and Australian Society recommends something else. It depends upon where you are, what you are comfortable with the practice, but at least once in 6 months, ultrasound is the minimum as I see it, like unless the patient develop any symptoms in between.
Thank you. And I think this will be our final question. It's again from an anonymous attendee, which is unfortunate because it's a really interesting question. A lady has had her menopause in the early 40s. She had severe menopause symptoms and didn't consult any doctor for 10 years. Is it good to start HRT now that as she has attained her menopause 10 years ago? And in the good old-fashioned essay questions, I will ask you to give reasons for your answer. So we'll start with Dr. Pardon.
Yeah. So this is unfortunate. I do see a large number of women here, like who've been at premature menopause since the age of 35, 38, and been to the gynecologist and like nobody has recommended HRT. They come to me when they're nearly 49, 50, 51 to say like, doctor, like, is it too late for me? Like I just find out through my friends or, I did research and I should have been on it, but nobody put me on. So there is, better late than never because HRT still offers benefit till you are the age of, before the age of 60 to 62, still recommended to have HRT. Ideally, they should have started a long time ago. And there are benefits, as we discussed already, numerous benefits. It still gives protection against osteoporosis and cardiovascular risks and Alzheimer's and dementia. So there is still significant benefits. Even women may not be suffering with menopausal symptoms currently, but they still get multiple benefits. So I do recommend. So after the age of 62 to 63, the perceived benefits are still there, but not as much as in the age group between 50 to 62 years.
Thank you. Dr. Marlene?
So there is no guidelines to say in the premature menopause women whether it's 10 years or after 10 years you can't use it. Even the guidelines says if a woman wants to start it, as long as you discuss with her the pros and cons, you can start the HRT even if she's been menopausal for 10 years or more. Especially on somebody like her, I would do a completely full health assessment, send her to the internal medicine, get her lipid profile assessed, cardiovascularly properly assessed, because do a bone density, because there is already significant health issues, and the research had clearly shown that even if you start HRT immediately in women who had premature menopause, they have more significant cardiovascular and health issues than women who start the menopause in the natural age. I will not definitely deny her HRT because she still will have a benefit from it, but I will do a full assessment and making sure her cholesterol level is low, because that is associated with the coronary heart disease, which is at higher risk in women in that age group.
Excellent. Thank you very much. Thank you very much to both of you, and thank you for everyone for attending. It's been really, really interesting. Fantastic topics, great answers, really, really explanatory. I've learned a lot. I will hand over now to Tawfiq, and before I hand over to him, I really would like to thank Tawfiq. He's done a fantastic job organizing all of this, and it's been a real pleasure. Tawfiq?
Thank you very much, all the speakers and Dr. Ibrahim, for this wonderful session. So inshallah, like for the attendees, you'll be getting the CME certificate in email within a couple of days, inshallah. Okay. So thank you very much, and let's plan for the next one, inshallah.
Thank you all very much. Thank you, Dr. Aparna, Dr. Marlene. Thank you really, really very much for all your efforts. It's been a really enjoyable session.
And thank you for all the people who attended and all the fantastic questions. Amazing, interesting questions. Thank you all. And thank you, Tawfiq. And Dr. Ibrahim, 100%.
Same from me. Thank you, Tawfiq, for wonderful organization, and Dr. Ibrahim for moderating, and Dr. Marlene, my colleague, and especially all these more than 700 participants, nearly 800 participants.
We had almost 700.
A wonderful audience with wonderful questions. So thank you all for keep us going. Thank you.
Good night.
Have a great evening. Thank you very much. And thank you all for attending.
Yeah, thank you.
Bye-bye.